So welcome and thank you all for joining us tonight. It's great to see some returners from our first session. So the AAP California Chapter 2 is pleased to partner with First 5 LA to implement the second of a series of 4 peer-to-peer learning sessions. These sessions are supported by the California ACEs Aware as a provider engagement activities to raise awareness on the impact of child adversity on health throughout the life course and what we can do to better address childhood adversity. The ACEs Aware is an initiative launched by the Office of the California Surgeon General and the Department of Healthcare Services with the aim of reducing adverse childhood experiences by half in a generation. Next slide. Here you'll see just a broad overview of our agenda for tonight. So we're here in the welcome. Moving forward, we'll have our lecture from Dr. Schickedanz followed by Q&A. We'll have a case study, a patient case that some of you may remember from our first session together, followed by our breakout session. You'll all be divvied up into breakout groups, and then we'll come back together in a larger forum to be able to share what we've learned from those breakout groups. And then Tina will go over the closing and the evaluation for how you can get your CME credit at the end. Next slide. So I know that we have been Zooming for quite a while now, but just some tips and tricks and a little bit reminders about how to be Zoom polite. So on entering, please have yourself on mute. You're welcome to unmute yourselves in the breakout sessions. If you're on the phone, you can press *6 to unmute yourself and *9 to raise your hand by phone. For those of you who are on video or have that nice square for yourself, you can add your organization to your name by hovering over your name in the participant box and then clicking that rename where those little 3 dots are. Feel free to use the chat box throughout the meeting. We'll be looking at that for our Q&A session. And if you can, join us by video. We would love to see your face rather than your name in a black square. So if you have any technical difficulties, please message our host, Tomas, and he'll be able to help you out. Next slide. So without further ado, the main act for tonight, I am proud to introduce Dr. Adam Schickedanz. He is a general pediatrician and health services researcher at UCLA who works clinically within the Los Angeles County Department of Health Services at All of You UCLA Medical Center. His work focuses on developing new models of pediatric primary care to address family, social, and economic determinants of health. He has helped large and small health systems and clinics implement assessment and evaluation programs to address patient needs, including food, housing, and transportation. Dr. Schickedanz received his medical training at UCSF and came to Los Angeles as a Robert Wood Johnson Clinical Scholar at UCLA. He received his doctorate in health policy and management at the UCLA Fielding School of Public Health, focusing on the relationships between adverse childhood experiences in one generation and behavioral health problems in the next generation of children. Dr. Schickedanz is currently on faculty in the UCLA Department of Pediatrics in Westwood. He is also the chair of the ACEs committee for our AAP California Chapter 2. Personally, Dr. Schickedanz was one of my precepting attendings in residency clinics, so I am honored to introduce him today. And now, Dr. Schickedanz, the floor is yours.
Thank you, Dr. Tang. Hi, everybody. It's nice to be with you through the power of Zoom this evening to talk about childhood diversity and health systems change. We'll dive right in. Our objectives for the didactic portion of the session are that by the end of the session, we hope that learners will be able to describe common barriers to identifying and addressing adverse childhood experiences, or ACEs. We'll be able to examine health system barriers to identifying and addressing adverse childhood experiences in their own practices, and we'll be able to assess their own readiness to deliver trauma-informed care in one's practice, one's own practice. I'll mention that I don't have any disclosures to report, and that this is the second of 4 webinars that are sponsored by First 5 California AAP Chapter 2 and funded through the ACEs Aware initiative. The first excellent session was delivered by Dr. Christine Pang back on January 7th. And I just want to recap what we covered in that session so that we're all on the same page and can pick up where we left off. Well, the first thing that we talked about in Dr. Pang's session, which was focused on the basic science of ACEs and toxic stress, was that ACEs are common. The cumulative impact of multiple exposures can be captured in the ACE score composite. I'll ask that everybody mute if they're not sharing or asking a question. Thanks, everybody.
Okay, what I'm gonna do.
So the ACEs score correlates with cumulative neurodevelopmental consequences of toxic stress and traumatic stress. And we can use it as a measure of early adversity that has a strong and graded relationship with numerous health, social, and behavioral health problems throughout a person's lifespan. Those health consequences and behavioral consequences are multidimensional, as is depicted on the left-hand side of the screen, and they are longitudinal over the life course. And they're thought to be mediated primarily through activation and dysregulation of the hypothalamic pituitary adrenal axis, or the toxic stress response, physiologic stress response cascade, leading to increased or dysregulated levels of terminal stress hormones, cortisol and norepinephrine, which have end organ impacts throughout the body and correlate with many adverse health outcomes. In the last talk, Dr. Tang also emphasized that there are important resilience factors that we should be aware of and thinking about and contextualizing people's exposures to ACEs and the life course health consequences that come with them. And those resilience factors can be summarized in the mnemonic threads, which stands for thinking and learning brain, meaning activation of that part of the brain as opposed to the reactive and surveilling portions of the brain. Hope, having hope through relationships, strong interpersonal relationships. Regulation or self-control in the child. These are all resilience factors. Self-efficacy, strong attachments to trusted caregivers, and developmental skills and maturation, and social connectedness, whether that be within the person's own family unit, nuclear family unit, or beyond into a broader community of social cohesion. When those threads are frayed by early adversity, we can see certain symptoms of exposure to adverse childhood experiences. And those symptoms are summarized in a mnemonic frayed that stands for behavioral manifestations, right? Including fits, frets, and fear that's displayed in the child, restricted development or developmental delays, attachment problems or concerns, yelling, acting out, or yawning, withdrawing from engagement with others, educational problems, academic difficulties, or displays of defeat or dissociation, right? Withdrawal from social relationships. So we covered all this in the last session. If you want more information on trauma-informed care implementation or thinking about early resilience factors and behavioral manifestations of adversity, I'd encourage you to check out the PATTER curriculum that's distributed through the AAP, which stands for Pediatric Approach to Trauma, Treatment, and Resilience. So that's where we left off last time. And I'm going to pick up by talking about a framework for thinking about early adversity and resilience in the context of the life course, which will set us up for thinking about systems change and how we actually adapt the healthcare system to be more responsive to early adversity and exposures to adverse childhood experiences and other social risks. So upstream healthcare and life course health are both frameworks for thinking about how health develops over time and in physiologic, biological systems like humans. And it posits that root causes of poor health outcomes are found upstream. What do we mean by upstream? Well, upstream could be in terms of the life course, right? They could be early in life, adverse childhood experiences that influence life course health development and later life health outcomes. They could be upstream in terms of medical diagnosis and care. They could be before a medical diagnosis, and in which case social determinants of health and other health risks might predispose people to later diagnoses or worse health outcomes downstream of those adverse social risks. So we can conceptualize the child's risk milieu, right, in terms of these risk and resilience factors that sort of cocoon the child, which are shown on the right-hand side of the screen. On the bottom, you see biological risk factors and resilience factors, genetics, biological programming, physiology. And above, you see social and economic risk and resilience factors, including family and interpersonal relationships, society, culture, and structural factors, right? We can think about these layers of influence on life course health, including both biological influences and social and economic adversity and resilience. What we know from decades of evidence is that we're much more alike genetically than we are different, which is why only about 10% of population variance in health outcomes is explained by genetic factors. But by contrast, 40 to 60% of population health outcomes is attributable to those social and economic circumstances, right? Those layers above, including early life adversity and adverse childhood experience exposures. So what's to be done is the main question. When we know that what happens here in early childhood, early in the life course, impacts health throughout the remainder of the life course on into old age. And it's worth noting that it's not just a single generation, right? Not just a single life course that early exposures to adversity might influence. This actually has intergenerational ramifications. So what's depicted on this figure is multiple life course trajectories, in fact. You can see that the blue individual along the bottom, whose entire life course is shown, their health and developmental trajectories above the blue lines actually begin before they're even born in the preconception phase, right? Where their parents, their mother, may or may not have been promoted to preconception health interventions or resources, and therefore may or may not have sort of moved that child's health trajectory onto the dashed line, which is a lower health trajectory, life course health development trajectory, or a higher dashed line with higher, better health outcomes, right? But as that child is growing up and their life course health trajectory progresses onto a peak in midlife, they again, in turn, have an opportunity to influence in their own children, the green individual lower here in the figure, that green child's life course health trajectory is determined by the preconception health state of the blue individual. So you can see on and on, we have this cascade of influences from early exposure to adverse childhood experiences, social risks, and resilience and strength, by contrast. So again, the question is what's to be done in the healthcare system, and how do we respond to this, given that in the healthcare system, we have a responsibility to ensuring and promoting optimal health outcomes? Well, in the last decade or so, we have seen, since the implementation of the Affordable Care Act, a shift from volume to value, right, which has given us more tools to actually adapt healthcare structures and payment to catch up with these upstream healthcare risk frameworks, right? We've seen the expansion of alternative payment models and value-based care, beginning with Medicare shared savings programs, managed care organizations that are able to coordinate care within the healthcare system to deliver better processes of care and ideally better health outcomes, moving on to accountable care organizations that are responsible for populations of patients and whose payment structures are in part determined by the quality of care delivered or the outcomes of those patients, again, based on coordination of care within the healthcare system. And we're moving into a new sort of frontier of alternative payment models that CMS is pioneering now, called accountable health communities, in which the coordination of care is not just within the healthcare system, but built on partnerships beyond the healthcare system, so that health systems are partnering with resources to address social risks like housing, food, and other social factors that community agencies are better equipped to deal with than the health system may be. These alternative payment models of various types, right, of various degrees of evolution, are CMS set a target of achieving greater than 50% of its payment reimbursements to be on alternative payment models by 2018. We're at about 41% now, but that number is growing and is the future of where healthcare payment is heading. We can see some of the sort of cutting edge of innovation in payment and structural reform in healthcare through state Medicaid waivers that are, in some cases, quite innovative in terms of their social risk-based payment. Many now support social determinants of health and social risk screening and intervention in the healthcare setting. And for example, the Massachusetts plan that adjusts Medicare managed care organization payments based on the presence of homelessness, right? It measures whether or not a person's had 3 or more addresses beneficiaries had 3 or more addresses in a given year, which would indicate that they're housing unstable. And if they also live in a low income, low education census tract, their payment to health systems that are accountable for their care actually increased by somewhere between, I think, $305 to $500, depending on the circumstance. So explicit social risk-based payment. There's further innovation that's going on beyond CMS, beyond Medicaid, at the state level and local levels, And one such innovative program is the California ACEs Aware Initiative, which is now offering Medi-Cal reimbursements for ACEs screening, funded by the Cal Proposition 66 measure. So lots of innovation here. This is where we're heading as a healthcare system, towards more integration and coordination across systems, inside and outside the healthcare's walls. And we're moving upstream, which means new partnerships. Practices are coordinating with upstream services to address adversity and social risk. We talked about the federal accountable health communities model, which is coordinating with social resources agencies to address food, housing, and so forth, and has actually shown in their early evaluations that emergency department visits are declining among their beneficiaries through that coordination, through a network, right, of resource providers that's moving further and further upstream. Here in California, the ACEs Aware Initiative is encouraging trauma-informed networks of care, which is another sort of formulation of that coordination across systems and across silos to incorporate more agencies that are traditionally focused on social risk and addressing adverse experiences and their consequences beyond traditional healthcare interventions. So addressing ACEs is really part of a larger shift upstream that will continue likely for decades, if not much longer, in the healthcare system. We're just beginning to see the beginning of. So with that in mind, we thought it would be informative and interesting for us to actually share as a group through a poll where we are in terms of our individual clinical practices, in terms of this progression towards systematically identifying and addressing either ACEs, early adverse childhood experiences, or social risks and needs, right? So we're going to ask you to participate in a poll through Poll Everywhere, and there's a, hopefully everybody sees this on the screen. The poll question, we'll talk about the poll question first and then how to respond next. The poll question asks you, in your own clinical practice, does your clinical practice A, screen for ACEs or social risks systematically and refer to resources outside the clinic? That's sort of option A. Or B, screen for ACEs or social risks systematically, but not refer to resources outside the clinic yet. Or C, not screen for ACEs systematically, do ACEs surveillance, and you're considering systematic ACEs screening in the future. Or do you not screen for ACEs? You're doing ACEs surveillance, but you're not really considering systematic ACEs screening in the future, or you're not sure where your practice sits. The way to respond to this poll, we'd love to hear what people think, just to sort of see in the audience where that stage of practice change is for the most part. You can respond via a web browser. So you can go to pollev.com/ACES poll, or text ACES poll to on your phone 37607, and you'll get a response that indicates that you joined that poll, at which point you can type A, B, C, D, or E into the text thread, and it will show up in the poll here. Go ahead and send your responses. I'll give folks about 30 seconds.
Adam, there's a question about what is systemic screening?
Oh, systematic, I guess is what I mean to say. So in a protocolized way. That isn't sort of ad hoc based on provider judgment. There's some sort of protocol in place in the clinic for doing that kind of screening. All right, is everybody seeing that? Great. So thanks to the 13 folks who were able to respond. These responses are actually quite similar to what we got from a survey, what we saw from a survey of AAP members that we fielded about a year ago. Dr. Denise Nunez at UCLA fielded the survey. And most folks are in this stage where they're not screening for ACEs systematically at this point, but they may be considering ACEs screening in the future. And about 46% of us tonight indicated that. Looks like there are about 40% of folks who are screening for ACEs systematically and are also referring for risks identified. And there are a couple folks who are not screening for ACEs yet and not considering that in the future, and someone who's not sure yet. Thanks, guys. All right, so the next poll question, let's see here, which is what resources does your clinical practice need to take the next steps towards systematically identifying and addressing ACEs? We'll ask you to choose one of the following. Resources being more time with patients, more training or guidance, clinical protocols to help with that process, care coordination resources, social work resources, mental behavioral health, or something else. It's not listed, or I'm not sure. So please respond in the same way that you responded to the last poll, by going or refreshing your browser page at pollev.com/ACES poll, or using the text response option. We'll do about 30 seconds for responses. Okay, so showing responses, it looks like most folks identified, or the majority, excuse me, a third of responses identified mental behavioral health resources as the single most important resource that they would like to have in their practice. Next up were more time with patients and clinical protocols, followed by about equally distributed care coordination resources, social work, something else, or I'm not sure. Thank you, everybody, for participating. And again, this is also very similar to what we found when we asked AAP members, about 166 AAP Chapter 2 members, to identify what resources they thought would be very useful to have in place to initiate ACEs screening and responses. Okay, so we're going to zoom through these slides and talk about the next step. So thank you for sharing where your stage of readiness is, everybody. And it sounds like we're in a very similar place to where a lot of pediatricians and child healthcare providers are now, which is thinking about ACEs screening in the future, but not quite being at the point of starting to do that systematically. And what I often say when talking with clinicians and practices that are just at the beginning of that process is that it's totally fine and actually quite important to start small in one area or a few areas of risk or need, and just add one at a time, and consider when you're choosing which areas of risk or need you want to focus on, patients and families' biggest risks, right? Ideally with input from them, from patients and families themselves, with their input on how they conceptualize that risk or need and what the resources are that they want to have connection to, access to, in order to be most impactful. It's also important for a lot of practices to focus on risks or needs with established interventions, where the referral pathway to getting to interventions to respond to adverse childhood experiences that are identified are very clear, and where there's a robust capacity to actually address the needs that are identified in the volume that they're identified. It's also worth noting for those who are at this stage of sort of practice readiness to anticipate pushback, right, and setbacks sometimes. Primarily pushback actually comes from well-meaning clinicians who don't want to re-traumatize or re-stigmatize patients who have experienced adverse childhood experiences. This is something we found over and over again in a series of interviews that Julia Redding, who's a medical student at UCLA, and I did, when we asked pediatricians who had implemented ACEs screening what the barriers were and what their process was like. And interestingly, while they found that there was a lot of pushback from clinicians early in that process, by the end of sort of a year of implementation, a few months of implementation, the pushback from clinicians had subsided in large part because many patients, the vast majority of patients, accepted ACEs screening. And in many instances, clinicians actually had wonderful conversations with their patients who had never really been able to find the right vehicle or find the right moment to share with that trusted clinician about this adverse experience that they'd had always carried with them in some form or fashion, or worried about or thought about in the context of their health, but had never really had the opportunity to talk about it with their clinician or figure out how to address it. So it actually opened up doors to really productive conversations, and that helped helped address the concerns that clinicians had initially. There's also a real important piece, which is that we want to design not just care processes, right? Not just add another question to your intake or add a layer of clinical workflow processes, but we want to actually design and change care experiences. The idea being that the focus shouldn't just be on changing clinical processes, but focus on how you make patients and families feel in the care continuum and care cascade. And that gets back to this really fundamental piece, which is that trauma-informed care is foundational to any practice redesign that addresses adverse childhood experiences, any ACEs screening approach. It's got to be in place first. Otherwise, if you're asking folks about sensitive topics, they don't have a trusted relationship there, if they don't feel safe, if they don't feel as though the relationship with the healthcare provider can sort of sustain that tension potentially that might be introduced through the screening, the responses will be less forthcoming. I think it's also worth remembering in the context of trauma-informed care and keeping these care process and care redesign processes aligned with trauma-informed care, that we should be thinking about ACEs just as risk factors in the context of the rest of the lived experience and healthcare circumstances of our patients. Just like LDL, high LDL, doesn't predict that a person is going to have a heart attack tomorrow, next week, or ever. It needs to be contextualized in other risk factors that we consider when risk stratifying our management decisions. ACEs that are identified through screening systematically need to be contextualized in the risk and resilience sort of context that our patients live, right? And we need to apply our clinical judgment. So I would encourage people to see the forthcoming AAP statement, policy statement on trauma-informed systems of care, which really emphasizes not just the risk factor, the ACEs that are identified, but also their symptoms and functional impact and the strengths that people may have to buffer those adverse exposures. All of that, I think if we can keep all that in mind, then we'll do our due diligence and not do any harm through screening and potentially unlock opportunities to serve our patients and their families quite well. Before we wrap up this didactic portion of the talk, I wanted to share a little bit of information and the findings that our group at UCLA came up with when we surveyed a little fewer than 200 AAP California Chapter 2 members about what would be useful as far as resources that they'd like to have to embark upon ACEs screening and response, and as well as barriers to practice redesign that would facilitate those screenings and interventions. This was fielded about a year ago, so in the pre-COVID era, and we asked these clinicians who were pediatric health care providers sort of across the spectrum, and they were not uniformly screening for ACEs. Many were actually not screening for ACEs or even contemplating screening for ACEs, so a general sort of pediatric population. We asked them what would be very useful as far as resources to respond to ACEs that they identified. And what you'll see is that they identified many different types of resources as potentially quite useful. But just like our poll here tonight, child and parent mental and behavioral health resources were top of the list. Care coordination resources and social work resources were also endorsed by over 2/3 of participants, those clinicians, and trauma-informed care training, as well as resources for connecting parents to parenting classes came up quite often. In terms of barriers that they identified, I'm showing this just to sort of normalize that this is the results of our poll tonight, and where a lot of us are is kind of what we have seen, what's pretty common among a lot of pediatricians right now, thinking about how they're going to move their healthcare practices upstream. What we saw when we asked about barriers to ACEs screening was that lack of time and resources were thought to be a major barrier or moderate barrier to most. Lack of training, lack of comfort in asking also showed up quite commonly, and lack of knowledge in terms of how to respond to ACEs that were identified came up a lot. There's no cookie cutter way of addressing these barriers. These are just barriers that practices face kind of across the board. And as we think about practice redesign, we need to be thinking about how to address these barriers effectively so we can move healthcare upstream to address ACEs. What's also I found been useful for clinicians who are thinking about moving towards ACEs screening and response is understanding, well, what does a workflow look like, right? Or what were a couple options for workflows that could be adopted to implement ACEs screening and response. And so through a series of interviews that Julia Redding, again, did at UCLA with over 20 pediatricians who had implemented ACEs screening and had experience with ACEs screening, I'm going to present a few different workflow models that I think sort of summarize the options that the vast majority of practices have adopted among those who have started ACEs screening. This will be presented in the process flow diagram format, so you can see with swim lanes, you can see the swim lanes for patient caregiver activities at the top, clinical staff activities in the middle, and primary care activities at the bottom. And this is the first type of workflow that I'll present. It doesn't have any, it has sort of the least protocolization, and it's most dependent on primary care provider discretion. It begins with patient check-in and then moves on to question delivery. So ACEs screening questions, either verbally or via questionnaire, via patient portal sometimes, actually most often through clinical staff and clerk distribution of the screening questionnaire or verbal question asking at predetermined visits. And in certain instances, the questions are asked by primary care providers themselves. Questions are answered by the families, and then in this particular workflow model, the primary care provider recommends intervention on sort of an ad hoc basis, right? Based on individualized clinical factors. And the intervention itself is also, the intensity of it is titrated to the appropriate sort of level based again on primary clinician judgment on an ad hoc basis. And so people access interventions based on that discretion. This is very common and a totally appropriate way to start doing ACEs screening in response. Type 2 of the workflows begins the same way, right? Patient check-in, they answer the questions. But then there's a protocolization step of introducing a threshold for who receives the intervention, right? So based on whether or not a patient meets protocolized predetermined criteria for intervention, which might be an ACE score, level of symptomatology, or combination of the two, or something else, that's what determines whether or not an intervention protocol is initiated, and it's a standardized intervention protocol. So anybody who sort of meets that threshold gets access to a sort of standard intervention, or maybe an intervention that isn't protocolized in any other way. Those who don't reach that threshold aren't referred to that intervention. So that's type 2. The third type of workflow has the most protocolization, not only of the intervention threshold, right? This initial step of figuring out, do you meet criteria to have some response from the clinician, but it also risk stratifies the intensity of the intervention. So does a patient meet criteria for low risk, high risk, based on symptoms and ACEs score, or mix of symptoms, resilience, and ACEs score, or something else? And then based on that determination, their intervention intensity is titrated to either high intensity or maybe low intensity or something in between. But again, it's tailored, in important ways to the needs and circumstances of the patient. So that's type 3 workflow. These are all out there. Folks are using all of these to successful effect. And I think it's just important to sort of see, what the variety looks like. So we have a sense of that at the beginning of this process, right? I'll also comment on the fact that the ACEs Aware Screening and Response Workflow, which the ACEs Aware Initiative has shared and is reimbursing for, would fall into that category too of ACEs screening and response workflows, where there's a protocolized predetermined threshold for intervention, but the, but the intensity of the intervention isn't predetermined or protocolized in any specific way. It's sort of tailored to the needs of the patient and the practice. That is the didactic portion of our session tonight. What we're going to do after this is actually a small group breakout session where we think about, with all of this information about how the healthcare system as a whole is changing and how practices have thought about resources needed, barriers to, and workflows that are available to begin systematic screening or identification of adverse childhood experiences or social risks. What do we think we can do to apply some of these practice change approaches to our own practices in the context of a clinical case that we'll be walking through in those small groups? Before we dive into that, I want to leave a couple minutes for questions, if there are things that have come up that we want to address. So folks who are on the host list, how are we doing on time? How many?
We're actually at 6:40 for our clinical case study. If anyone has a burning question, they're welcome to ask it right now. Otherwise, we could move to the clinical case if no one has a question.
Thanks, Christine.
Maybe we'll circle back for questions during the small groups or the big forum. Do you want to go to the
sounds
case?
good. All right. So this is a case of Henry, who's a 12-year-old boy. This is a case, names have been changed, by the way. It's a case that's brought to us by Dr. Adwa Osei, who is part of our California AAP ACEs committee. And on the last slide, there was a link to our California AAP Chapter 2 ACEs committee website. So if folks who are interested in taking part in that, please take a look and explore. There's a lot of resources on those websites as well as on that website, as well as a list of participants in the committee. So thanks to Dr. Osei for this case, which we introduced in the last session and went through in detail through the clinical case history, detailing this 12-year-old boy who has had multiple exposures to adverse childhood experiences, is now having behavioral and symptomatic manifestations thought to be related to those early adverse exposures. Rather than going through line by line through the case history, which folks will have an opportunity to do during the small groups, and we also did in the last session, what I'd like to do is present this case synthesis, which I think will be a better jumping off point for thinking about practice redesign to address the types of adversity and risks that this child has. So I'll emphasize that in this case of Henry, 12-year-old, over 3 clinical visits in roughly 3 months, we'd like you to imagine that Henry was in your practice and that you identified that Henry had a history of multiple ACEs, including parental separation, witness to physical assault, leading to the death of an uncle, maternal mental illness, possible bullying at school, and also you identified that he has behavioral symptoms consistent with depression, possibly, plus episodes of passive thoughts of self-harm. He is socially isolated and has multiple school transitions that have left him socially isolated. His sleep hygiene is poor, and he has some apathy regarding academics and academic struggling as a result. And he also has strengths, including strong relationships with his mother, grandmother, and church community. And he's been willing to engage with you in productive dialogue and sharing where he is in terms of his early adverse exposures. His mom has been open to sharing some of those as well, and he seems to connect with you well. So, but it did take some time, right, to get to this point where you have a case summary, sort of get a clear picture of all that's going on in terms of Henry's exposure to adverse childhood experiences and symptomatology and behavioral manifestations. It took that, multiple visits in 3 months. So the question that we'd like you to consider in your small groups is how you might redesign your practice to here are the objectives. But the question that we want you to focus on in the small groups is what routine practice changes might have made identification of ACEs in Henry's history more straightforward, if there are any changes that you think might have led to that. And the answer might be that, oh no, it takes time and relationship to get there. But we'd like you to consider at least what routine practice changes you might want to implement, thinking about your own clinical practice. And if you had seen this kid in your practice, what you may be able to do to, again, expedite that identification of early adversity and facilitate the response. So that's the first question, the main question we'll ask you to address in the breakouts. Next, we'll ask you to consider in your breakout groups how you might overcome potential barriers to these routine practice changes to identify and address adversity. So, identifying the barriers will be simple, but finding ways that in your own experience, you might be able to overcome those barriers is really the thing we'd like you to focus on here. Then if you have time, thinking beyond just the microsystem practice changes, we'd like you to consider, well, what about the macrosystem? What kind of policy level and sort of clinic network changes might facilitate these practice improvements and lead to more facile identification of adverse childhood experiences, whether through screening or other mechanisms, and better responses in a more systematic way. So we'll come back for an idea share at the end to talk about what's been discussed. So I think from there, we're going to create the breakout rooms, and you'll find yourself assigned to a breakout room with a facilitator who has a facilitator guide. And we'll come back in a few minutes, in about 25 minutes. Thank you, Anne, for putting the breakout objectives and breakout questions in the chat. So we'll come back in about 25 minutes after we join our breakout groups to do an idea share out and talk about what was discussed. All right, it looks like our group size isn't changing anymore. So I think everybody's back who's gonna be back. So why don't we just hear for the next few minutes or so, 10 minutes or so, from the groups. So anybody from the groups, reporters, willing to briefly summarize the group's discussion? We'll talk about a couple surprising points that came out of the conversations. You can call on group one if it'd be helpful to have that structure, or if anybody's sort of raring to go, feel free to jump in.
I'll do group two.
Thanks, group two. Go ahead.
Yeah. So we talked a little bit about how to get information and a little bit more, maybe more effectively or sooner. And there were ideas thrown out to talk to the grandmother, maybe try and get a hold of the dad, some people at school, especially important talking to the kid. In order to get them over a barrier of not wanting to do this screen, we could mention that we do this for everybody. And tell them how important it is for their future health. And that's what we're trying to help fix ahead of time. But then there was also the idea of using the anonymous score where they could just tell us, oh, I got a score of 4 or 5 or whatever, without telling us exactly what was happening. And that might be a good a way to open up the door to talking about some of this stuff. In terms of getting policy to help with all of this, they already incentivize. It's, I guess, $29 for doing the screen, which is not a huge amount of money. But it is something. And then the other thing that we talked a little bit about was that this is something that we're not only changing the people's lives in the future, the kids as they become adults, but their kids and their kids' kids. So it's actually money saving. And I think we decided we probably need to invest more in the kids.
Yep.
I think those
make that case.
And
That's
actually great. It was surprising how many ideas came out, and we all kind of are passionate about it and really kind of feel the same way. I think that was, it was nice.
Sounds like a very rich discussion. Thank you. It sounds like you identified some microsystem practice changes and some more macro sort of system level changes and approaches to advocacy towards, health system leaders to sort of make the case that, investing in these upstream practice changes.
We had a really good leader.
Long-term benefits, yeah.
We had a really good leader.
Great. Thanks, Anne, for taking notes. Others from other groups who, glad the leader was great. Any others from other groups who want to share out?
Yes, this is Nisha, and I was in group 1. And we had a great, interesting group with a couple of pediatricians, but other areas as well, family medicine, as well as some people who weren't pediatricians or actually physicians. So it was great to hear the different ideas people came up with. Kind of on the outside end, you know, the need for more resources is definitely an issue that continues to come up. But some really interesting ideas about the concrete need for incorporating ACEs into screening tools that are user-friendly formats was really important. So to make sure that that was user-friendly. The idea was brought up about using things like care managers, peer educators to help to do those screenings so that they have the time and are able to make that relationship with the family as well as the youth. We did also talk about making sure that there's time alone with the youth and that they also can do their own screeners as well as not just the parent. And lastly, we talked a little bit about sort of like that system level changes, thinking about using multidisciplinary systematic case reviews. So really looking at the data that your clinic or your practice is coming out with as far as those, maybe the pearls or the ACE screeners that you're doing to help guide how you're going to go forward. And as you brought up about the workflow models, different practices are going to have to develop that workflow model differently if you're in a higher risk population versus in a lower risk population, and how you're going to identify which services are needed. So those are some of the things that we came out with in our group.
Fantastic, fantastic. Thank you. Thank you for sharing. Others? Other groups?
Hi, I'm Dr. Sheth. I'm from Group 5 with Dr. Adam. Of course, it was a very good discussion and presentation by him. We learned a lot. But our group, one of the pediatricians had a great idea about doing at the community level, where all the pediatricians during COVID got together, and they meet every Monday on Zoom, and they have 2 parenting groups. I mean, they have parenting teachers who teaches and talks to parents about how safe to be during COVID time. So that was an excellent idea. And every small town, if pediatrician can get together, and as Dr. Nisha said, that if you can figure it out, what are the major ACEs factor in your community, then I think we are climbing 2 steps rather than 1 step forward. It will be great things to do, put together. Also, basically the summary was that I think because we as a pediatrician, we have more time, our group agreed that we have so much time right now that we are talking to parents, we are talking to the kiddos, and we are asking them in detail about their life, about their school, about their Zoom time, about their friends, if they are seeing it, if they're missing it, if they are doing well at school by themselves, because there is a social anxiety which we never knew that was a bad thing. And many kids who has a social anxiety disorders, they are doing very well on Zoom. They are getting A+, and they don't have to deal with bullying. So I think basically it boiled down that we as a pediatrician have more time, and we are going in their life in more detail, and they are confiding to us. So of course, Henry has church, Henry has his mother, but mother always tells, so Dr. Sheth, you tell them, they will listen to you. So I think you are the biggest trust factor. So I'm not sure how the idea of hiring second person is going to help us out. I think we just pediatrician has to do it. And then Dr. Booth said that yes, it is $29, but I think in $29 we are getting a lot of improvement in our patient's life and parents' life, and hopefully we continue and we have more resources so we can do better as a team. And I think we all are into it. Looks like we are all passionate about it.
Great summary, Dr. Sheth. Thank you. Other groups who want to share out in the last couple minutes that we have?
Yeah, Adam, I'll just share an interesting point from group 3 as we talk about like policy level, macro level. Really getting one thing that was brought up with pediatricians and family medicine was getting, I guess, the legal system sort of on our side too. And I feel like what was shared was how like sort of child protective services is sort of your go-to, right, in terms of legality. And we think about, who is the best supporting adult caregiver for the child. Do we have a say to where they go to? I think especially when you're going through ACEs, a lot of the repercussions are, they're very punitive, right? When you think about the legal system. So in terms of like higher level, something along those lines. Yeah. And of course, like time and mental health access and partnerships with mental health and more time for adolescent visits, similar to what was brought up in other groups as well too.
Yeah, that's great. It's a great point. And something that I think is worth mentioning that I learned about a couple of days ago is that DCFS actually has a consultation line. You don't have to call in a report anytime you have sort of a circumstance that may or may not fall into a bucket of let's see, abuse or neglect. You can actually call that consultation line to see, what are some of the resources that I could be availing myself of? Do I need to make a report for this? And they'll talk you through a bunch of different options. I think a lot of people have a lot of consternation around, our ACEs screenings going to lead to a bunch of DCFS referrals. And they, it's important for all of us to be aware of the resources that we have available. Think about, the information we gather through the ACEs screening and trauma-informed lens. And I don't have the number offhand for the consultation line, but maybe that's a follow-up that we in our group can put out there for participants, because social workers that I work with have found it very useful in the past. So thanks for bringing that up.
Adam, the question is, is everyone able to access that line?
Yeah. Yes. Sorry, I misinterpreted the chat. Yes, everybody is able to access it. Any mandated reporters and others.
So yeah, Adam, I just wanted to add a little bit from group 4. I think we had one present question, and that was, how aware are the big social systems about ACEs? We do all this work in our clinics, but what is our view outside of our world? Because we can pick up everything we want, but if there is no support from Big Brother, then that doesn't help anything. So that's the one question that we had. And one of the things that we talked about in our group was the form filling fatigue that patients might have. It's a whole bunch of things they have to fill out when they show up for visits or before they come for visits. So that was one of the barriers. And one of the things we discussed was maybe we could think about, being trauma-informed when we're giving out these forms, and actually giving people time to take some of these forms home, provided that we are sure to follow up, and then they can bring it back, and then things can be discussed. And when forms are filled out, people need to know that things are being followed up, not just fill the form and then it's shelved somewhere and no conversation is ever had about it. It's just some of the things we talked about.
Great. Thank you, Dr. Osei. All right. About 5 minutes left before 7:30. So unless there are sort of burning share outs, I'll transition back to our slideshow here, and Tina, take it away.
All right. We wanted to thank everyone for attending this evening. We are so pleased to do our second session with AAP Chapter 2. This series is funded by ACEs Aware. As part of the statewide initiative, we need to report participant feedback. So we would very much appreciate everyone completing the post-session survey. The link will be shared in the chat, and will also be emailed to you as a follow-up email tomorrow. Note, if you're obtaining CME credit, you're required to complete the survey. And again, the survey link and the meeting packet will be emailed to you for participating this evening. So please do join us for our next session on March 18th. Dr. Carlo D'Antonio will be presenting on after screening, building ACEs response interventions and overcoming barriers to referrals. And the link to that, to the website to where you could register, will also be shared in the chat. And thank you very much for joining us this evening. We're pleased that you've joined us for this series, and we're very pleased to be working with AAP Chapter 2.